That being said, again, we're going to talk about the scapula, or people refer to the shoulder blade. And I can't tell you enough how many times when I'm dealing with just any kind of shoulder issue, how most people tend to focus on what I would call the lesser portion of the shoulder, which is the humeral head, or the ball, if we're talking about a ball and socket. And so the scapula really is the platform from which a shoulder, is able to do things such as throw a baseball, a javelin, hit a tennis serve, those kind of things, swimming, etc. It is what sets human beings apart, and primates from a part of all the other animals, our ability in our shoulder and the degrees of freedom and the ability to use it. Obviously, we're talking about today in regards to sports and specifically throwing. But when you stop and think about it, it's really a marvel that we are able to do the things we can with our arms. That being said, let me see. Am I able to share?
You should be able to.
I'm about to right now.
To be the host, and it should allow you to. Okay, good.
And here we go. So, and hopefully you can see me. And again, that's me. So this slide is kind of busy. All I want you guys to be able to see is all of us have seen this before. Someone throwing, someone pitching. The key thing is us as physicians and therapists and trainers, we break down throwing into several phases. And most people will recognize these. There's the wind-up phase, and we can discuss what happens during each one of these things. But for the most part, it is when basically the pitcher is winding up, flexing the lead leg and pushing off the planting leg, and starting the sort of building of kinetic energy before thrusting forward. The areas that we're going to talk about today that are really, really important with the scapula are these areas right here. And hopefully you can see my arrow. It's the C, D, E, and F. G is kind of follow through. And again, you can kind of see if you look at it from the side, which I personally like to do, and that's what most doctors and therapists do. But obviously, a lot of times, you as a coach, or if you're throwing and doing batting practice and things like that, you're going to see this upper view more often than not, and you're going to have to wait for video, etc., to get this. But hopefully you understand that you kind of need to look for certain cues and keys on both of these. That's more of another discussion. But again, I want to bring this up just so we have an idea of what we're talking about, because there's going to be some terminology I'm going to use that hopefully we'll all understand. And the ones we're talking about are these scenes right here. When we talk about what's called the late cocking, early cocking phase. Early cocking, you can see the arm is back, down from behind the body, and it's going to come to the full sort of behind the body, what we call externally rotated position. And then obviously it's going to accelerate through, which is the acceleration phase. And then it's going to decelerate as it comes across the body. Those areas, while we'll talk about the legs, the torso, and the core. Obviously, those are incredibly important. And this doesn't exist in a vacuum. All those other muscles and things are working in conjunction. We're going to talk about these three areas, and we're going to talk about this number right here, the scapula. And if I can just point your attention here, if you just take these four views right here, you can see where this pitcher's scapula goes from here back here, where it's sort of kicked back and pulled away from the body or retracted. It then sort of slides out and then comes and flattens against the body and is protracted. And so not only is the scapula moving in a position where it's going against and away from the body, but my hand was the scapula, or we can use our one here, the scapula, not only is it pushing forward and back, but it's rotating up and forward and back, depending on what we want it to do. And so obviously all these muscles here that are going to attach in your scapula play a dramatic role. And I think people sort of get a little bit focused on, well, hey, there's these muscles and they're really, really important. That's not it. And we're going to discuss a little bit of the anatomical considerations next. this is a little bit of a busy slide. The main reason why I'm talking about this is, and some people may understand these things and they may not. It's not really important here, with the exception of these last two here. We are talking about what's called a breakdown of what's called the kinetic chain. This is a fluid motion, right? So the kinetic chain is multiple movements of multiple joints to have one seamless pitch or throw. So if at any time point these things start to have issues, or you have malalignments, muscles that don't work, sort of misfiring of the muscles in conjunction, sort of like a distributor cap. If they misfire, the timing sequence is off, there's going to be issues. But we're going to talk today about these couple things. One about the external rotation of the arm. And I think a lot of people who are familiar with baseball, they understand that external rotation is going to be the key to velocity. And I know obviously this is what we're looking for most pictures. Absolutely, Jack. We're going to get that arm back. And most doctors, therapists, etc., if we look at people, and we don't even have to really ask them a lot if they're right or left-handed. If we just have them do this, we know what hand dominance they have because of the increased external rotation that is present pretty much for the entire life. Likewise, this last portion here, scapular dyskinesis. This is, again, what we're going to be mainly focusing on. And what happens is you have diminished external rotation because the scapula doesn't move the way it's supposed to, or because the scapula doesn't move the way it's supposed to, and you're trying to generate that external rotation and or velocity, it causes injuries to the structures within it. So let's start with anatomy. I'm sorry, I'm checking a text message because I think I'm on call, so I got sorry, I got called. So okay, we're looking at this model here, kind of like what the model I have here on the shoulder. Okay, and I have it facing you. This is sort of anterior front, and then this is back. And I picked the left shoulder because I know you guys all like the lefty pitchers because those guys are special. So that's for you guys. You can see, and this is similar to this, but it's a little bit easier to see. This is the fossa or the blade of the scapula. Things that are going to be important here. One is this process right here. It's called the coracoid process. We're going to talk about this because a muscle that a lot of people are probably aware of and can play a role here is called the pectoralis minor. And that attaches there. And the pectoralis minor also attaches to the chest wall. And we'll show you some of these other things. The other bony aspect that we're going to talk about is this bone here called the acromion. To put things in perspective, this is the glenoid or the socket. And again, all this is one bone. And again, why I emphasize the importance of the scapula in this whole process. That being said, the clavicle plays a tremendous role as well because it attaches to the sternum, which attaches all these muscles, the pectoralis minor, etc. Here is the humeral head, and that's the part that articulates with the glenoid. I want you to understand something here, and we'll talk a little bit about it, is that if you look, the humeral head does not point directly straight ahead, nor does the socket. There is a degree of what we call version to it, and we're going to talk a little bit more about that, but that version changes and is different in people who are overhead athletes, particularly if they're pitchers, etc., because if you change the version of the socket, so I'm going to kind of take my little thing here. If you look at the front here and you talk about raising your hand and going like this, so if I raise my arm like this, the more that the back side of this socket is tilted, the further back I can get my arm. And that's going to be a big importance when we talk about development. There are a ton of studies. They were done, initial ones done by Dr. Andrews played a role that most people know about, and other places where they studied that if you don't throw as a youth while these bones are growing, you will never get the change in version, the little posterior slant that you need to be able to throw very fast or with high velocity. Just as a side note, you can see we've got the other end of the humerus bone there, and that is obviously a big lever arm. Most people realize that the longer that lever arm is, and the more rotation you can get, the more what we call angular velocity you're going to get. And obviously that transmission of those forces gets transmitted downstream to the area here at the elbow, which obviously people understand the Tommy John and all that stuff, and that'll be for another discussion. I'm going to pause for a second. Are there any questions or anything yet? Plus, I'm going to take a sip of water.
Jason, quick question for you.
Yeah.
You had made reference earlier that the retroversion of your ball and socket joint can ultimately kind of be changed based on your throwing at an early age.
Yes.
Your body getting used to that. The question that I have is, how much, and is there a delicate balance between introducing the throwing motion at a young age for a player in order to have those anatomical changes take place, but putting him in a position where it's gone overboard and it's too much? Is there that fine line between the two where you can kind of create that balance?
There is. That's a huge question, actually.
Right.
The simplest answer is that we know, as long as we have kids use good form, I think most of the coaches and probably some of the parents understand, if we have kids just concentrate on good throwing mechanics, throwing just normal fastballs, or throwing as far as like making plays in the field or outfield, etc., that there's not been any sort of detrimental effect to throwing at an earlier age. And we know throwing earlier puts differential stresses on these bones when they are younger, and they're not actually bones, they're partially cartilaginous, which changes the way they ossify, and that thus changes the version of it. So the long story short is, if you do it in a safe fashion and you don't overtrain and throw year round, that most kids tolerate this very well, even at an early age, as long as we're not throwing curveballs and all sorts of sliders and easy stuff and pitching all year round, et cetera, et cetera. Does that help?
We got a question that came through, Jason. It says, what's the average age of boys when those bones stop growing? So in other words, when is it too late for those anatomical changes to start taking place?
That's an excellent question. I'm actually going to address that a little bit here in a little bit, but about the age, if you don't start throwing by the time you're in your teens, you're probably going to be a little late. Doesn't mean you can't, because some people obviously go through skeletal maturity and puberty, etc., later in life. But in that teens, 13, 14-year-old range, you kind of have missed the boat. Continuing on. So talking about muscles again, muscles that we're going to talk about a lot because it plays a big role. This one right here called the pectoralis minor. Most people are pretty familiar with the pec major. But the thing that's important also is these muscles, again, they're on the front of the scapula. And we're going to talk about balancing forces. So you're going to see, if you understand where these muscles are, you kind of understand what they're going to do in relationship to the scapula during this whole process. And this muscle here, a lot of people don't understand, may not have heard of it. It's called the serratus anterior. It attaches to the ribs and then attaches to this front part of the scapula. And just as a side note, as it contracts, it kind of snaps the scapula against the rib cage. Remember, the scapula sort of is floating in space. Not really, but it's floating in between these muscles, and the rib cage is underneath it. So you can use that rib cage and the serratus anterior and the muscles underneath as a platform. And obviously, I think everybody understands, if you try and push something and you have a solid base, it's much different than if you push something and you don't. It's like trying to push something in a canoe. You're not going to go very far. So again, these muscles are in the anterior or front portion. You can also see some of the muscles here of the neck and the trapezius here that we're going to talk about as well. So here's the posterior muscles. And you're like, well, wow, that's really busy. And yes, because if you look at the scapula again, here's the front. And one of the main rotator cuff muscles that sits right here is called the subscapularis. It's the only one we kind of didn't talk about too much because it's the only one that sits here. And it attaches to the front part of the humerus right about, if I can hold my fingers, right about here. And so that internally rotates the arm here. So if I hold it from the side, doing this or doing my arm behind my back, that is called internal rotation. And it's caused by a bunch of different muscles, but the subscapularis is one of the major ones. These are the muscles in the back. I think most people are familiar with the trapezius muscle. And the interesting thing about the trapezius muscles is it's bipinnate. So it has two sort of angles of movement. So when you contract your trapezius, not only does it pull your scapula in or medially, but it elevates it up and it pulls sort of this inferior border here like this a little bit. Obviously, people are familiar with the deltoid. Most people, I think, are familiar with the fact that deltoid's got an anterior component, a lateral component, and a posterior component. And obviously, each muscle pulls the shoulder in a different direction, so to speak. But the main thing is it gets the shoulder to what we call abduct. This is called abduction here. Finally, well, once we strip away sort of those peripheral muscles here, you can see the muscles underneath. These muscles right here are called the rhomboids. And then there's another muscle called the levator scapula. And medicine's really cool. They have names, particularly if they're in Latin, that basically describe what the dang muscle does. Levator scapula, it lifts the scapula up, duh. There's also some muscles here that are all sitting on the back side of the scapula. Remember we talked about the subscapularis. These muscles may be muscles people have heard of. One's called the supraspinatus. This one here is called the infraspinatus. The one down below is called the teres minor. Those four muscles, the subscapularis, the supraspinatus, the infraspinatus, and the teres minor, all attached to the humerus via one large tendon. I'm going to go back and forth a little bit. And I want you to kind of understand this. These muscles, this is looking at the socket from the side. So this is where my arrow is. This is the back or posterior. This is the front or anterior. The front is mainly sort of protected by the subscapularis muscle. The top is mainly protected by the supraspinatus muscle, and the back and top is protected by the infraspinatus muscle and the teres minor muscle. The shoulder is also in a capsule. So, and what I like to tell people is, and you can see this, the top sort of 2/3 is covered by muscle. The bottom third here is like a hammock. And you can see this thing called A and C, and it's just like a hammock where there's two cords and sort of a hammock in the middle. That's the capsule, and that is called the inferior glenohumeral ligament. The reason why it matters is because that ligament is what stretches out, particularly here in the front and less so in the back, for people to have lots of motion in their arm. And so when you look at the socket here, you want the ball to sit right in the center. The way you get the ball to stay in the center is to have all of these forces coupled perfectly. And you need to have balance. You can't have one side be incredibly loose compared to the other side. And that's when you start having issues and problems. And again, I can't emphasize enough that this is a combination of these ligaments which do not contract. They are basically just there, like a hammock is. And the muscles that surround it, with the exception of that sort of inferior portion, that have the hammock holding it together. In order to throw, when the ball rotates, it moves to a position of what we call external rotation here, and that puts a tremendous amount of stretch all on this front part of the capsule. So if we go back a couple slides and you saw that picture where the guy's got his arm here, we're going to put a lot of stretch right here. And we need these muscles to contract to keep the ball from leaving the humeral head, from leaving the socket. But what it does is it puts a tremendous amount of shear forces on other areas. And we're going to talk a little bit about that as we go along. We okay? We got any other questions?
We had a question come across a second ago, and it said, since boys mature at different rates and age isn't the true metric, how do you know when a boy is ready to learn a curveball?
Oh, wow. You got some easy questions, right?
Let you handle that one.
That is, yeah, that one, I mean, again, that is an absolutely, that's a lengthy discussion. There are things that we can do radiographically. We can do x-rays, and I can tell you to a degree of what someone's sort of skeletal age is versus what their actually numeric age is. That's probably the easiest way to describe it. Obviously, we can look at other things like as people start maturing, pubic hair, voices deepening, etc. For girls, it's when they start having a period. Those kind of things all give us biological indicators of when someone's sort of going through this last phase of growing and maturity. Does that help?
Yeah, I mean, I also think too, and I mean, this is outside of more of the anatomical perspective on that, but you know, in the same sense, you would have to be able to have a very good understanding of the mechanics for pitching as well too, when it comes down to developing multiple pitches. I mean, obviously you want to have as best mechanics as you can, but the truth is like, you know, learning multiple pitches really depends on your ability to reproduce your pitching mechanics. I mean, you're a former pitcher. I mean, you would be able to answer that question more so, but in the same sense, it's like, you know, I think, you know, that would be more of an indicator as well too, is how well the individual, regardless of physical maturization, is whether or not he understands his mechanics and his body at that point.
Absolutely. And as a physician, I do not recommend, and we have some hard rules, like we have tables and things like that, and people may have seen that, when we recommend people can start throwing curveballs and how many they're allowed. And I think obviously people understand the concept of a pitch count and those sort of things. And in my mind, I would not advise, or I advise parents that I wouldn't have them throwing, sliders, curveballs, etc., until they are comfortable and mastering and have what we feel like is optimal form for them, which is, again, a whole nother discussion, arm angle, et cetera, et cetera. Once we've got them sort of optimized and throwing well, and more importantly, I guess we'll take a step back. We talked about the trunk and the legs and all that stuff. Well, that's the other part of the equation. You can't have one part of the body be too far ahead of the other. I think we all have seen young ladies and men who are starting to sort of go through this process, and they tend to get very big and strong in one or two areas, and they're not quite there in the other ones. And so that's a setup for an issue as well.
Dr. Noel, just one interesting point, and it's kind of to go back a little bit to the external rotation. And, you know, my job evaluating pitchers, one of the things that I try to pay extreme close attention is, especially with high school pitchers, is what's their their degree of external rotation and how far back their arm, lays back in terms of like projecting future velocity. And when you said that, it was I just kind of lit up, because that's something that I spent a lot of time focusing on in terms of like projecting velocity down the road.
Well, and the studies say that metric is actually fairly worthwhile, and I think you're going to like a couple of the slides we have up here in a second. But to go back to anatomy, we'll talk about one other thing. This is the labrum. This is the sort of, it adds to the socket. It deepens the socket. It is what we call fibrocartilage, and it deepens the socket. But again, it's subjected to some tremendous forces, and we can get injuries to this labrum frequently down at the bottom half of this, what we call the inferior labrum, or the top portion of this labrum, called the superior. When you damage the superior portion of the labrum, most people, particularly pitchers, baseball, etc., we refer to this as a slap tear. And really it's an acronym for superior labral, and the A to P stands for anterior or posterior to this guy right here. This is the biceps tendon. And this actually, believe it or not, comes from your biceps. If you look at my little model right here, I don't know if you can see, there's a little groove, and the biceps tendon comes over and rides on top of the humerus. So if I were kind of to match it up, if you look at my picture, I'm now pointing it like it's going into the socket. Well, the biceps tendon comes over the top of it, and now it's pointing just like that into the screen where that biceps, I'm trying to use my finger to connect it, where you see there. And it's very important because it depresses the humeral head. The problem is when this humerus is moving all around, it's subjected to all these forces, it puts, again, a ton of shear on the biceps tendon and the labrum, particularly if portions of this, the capsule down below, are tighter in some areas and looser in others. And this is going to be a very common theme. We're going to talk a little bit about some of these stretches you can do if we have time to get to it. And that is going to be the key thing, because I think most people are probably familiar with a slap tear. A lot of times, if they're not even familiar with it, they'll be familiar with how the person presents, which is, hey, coach, I got a dead arm. Or, you know, my arm's dead. I don't have the velocity. I can't throw. And that is when the minute a patient comes in to see me and the dad or the mom's like, he has no velocity anymore and it hurts. Not always, but most of the time it's like, I know they've got a slap tear, and the reason they have the slap tear, we're going to get to. So this slide's a little fuzzy because it took me a little time to find some, but this is basically what we're talking about. This fossa has a certain amount of tilt and retroversion, averages 7 degrees as far as the fossa. The overall glenoid version is, again, 30 degrees from going anterior to posterior, and the humerus is tilted as well. Those fusion sites progress over time. I actually thought I had a slide for it, but I think I took it out because I didn't want to be too overwhelming. But suffice to say, most of the growth in the humerus and that area of the glenoid takes place around ages 6 and about 14-ish. You still will have a line in the humerus right about here, past that time sometimes, and sometimes that growth plate right there will pull off because there's abnormal forces to that growth plate. And most of us have probably heard the diagnosis for that. When there's too much force on that growth plate and it starts to separate, it's called little leader shoulder. And I'm sure most of us have probably seen someone, know someone, been involved with something like that. So again, we were talking about what you were saying, Jack, mobility differences. This, if you look at this slide, obviously this individual has got a tremendous amount of external rotation. And we know that that generates velocity. We also know that if he's doing this with this arm, this is probably what his socket looks like. And I think you can and you can also see that there's a tremendous amount of force, and the humeral head is now wanting to translate posteriorly. Now I'm showing you this, and I don't want to confuse you. This slide here, his humeral head is not doing this during this slide. Actually, when your arm is in that phase and about to throw, it actually puts a ton of stress and wear on the anterior part of this socket here. So you stretch out this entire sort of bottom front portion of what I call the capsulolabral complex. So it's the labrum and the capsule. When you look at it, they are distinct, but they sort of meld together. It's not as you know, as it shows in this picture, where it's like these discernible structures, like structure A, structure B. You can make them out, but they all sort of come together. So again, in order to get this degree of this, you have to have significant version, and you have to stretch out this portion of the capsulolabral complex. The problem is that when you do that, it tends to come at a sacrifice of the ability to get your arm to internally rotate. So if I'm holding my arm here, and I would call this sort of, this is abducted, moved away from my body. That's external rotation, 90 degrees. And this is internal rotation. It's not quite 90 degrees. And again, just to kind of show you, if you look at me here, I don't know, I think people can see me. You can see I go back further. I'm right-handed, right? And so obviously if I go here, you can see that my left arm goes a little bit further than my right. That is, you should have approximately a full arc of about 180 degrees. And when you start losing that, it is because, and we're going to talk a little bit about this, it is because this area here posteriorly gets significantly tighter. And it's very, very important that when you have this arm like this area is stretched. Well, what happens is not so much this, all these structures right here tend to get a little bit beat up during what we call the acceleration deceleration phase. So, So again, if you look here, this is looking at shoulder mobility. And this slide is generally pretty simple. The one thing I want to emphasize to people is you'll notice that he has more range of motion in one than the other. But the total arc of range of motion is 180 degrees. Sometimes it's hard to measure internal rotation. So another way sometimes we measure internal rotation is by having the hand go behind the back and measure how high up the back it can go. I'm gonna go back a little bit here for a second and talk about all those muscles in the back are going to help stabilize this area. All these rotator cuff muscles, all these guys here are going to help stabilize the shoulder blade, but also act as that restraint, not only in the front to a degree, but the back. And again, remember, there's not as much stuff in the front, right? So it's a little bit easier to stretch that out. And you actually kind of need to in order to get this. So,
go ahead. Quick question that came through. Says, how do you determine if a young pitcher's arm angle needs to be corrected to avoid injury, or whether to keep it in the same if that is how his body moves naturally? Examples would be pitchers who throw more 3/4 as opposed to over the top, arm angles outside of the recommended 90 degrees. There are pitchers who throw effectively outside of 90 degrees and without injury, yet who end up with the UCL or elbow injuries.
So absolutely, we know that having the arm, and again, this is one of those questions where it's like, this is a whole nother talk.
Yeah, okay.
But that being said, I mean, you think about like Linscomb and, Randy Johnson and guys like that who have crazy arm angles, etc. Those people and those arm slots, we feel, at least at this point, there are some optimal ones that drop out those areas. If you don't keep the arm in the optimal area, we know from biomechanical studies that does put an increased stress downstream on your elbow and other areas in the shoulder. But based on, and its other measurements, your trunk, your core, your legs, these other things, that's how it all plays together. And likewise, some people believe that when you start throwing may play a role in the development of the arm slot, because as those bones ossify, it changes not only, I know I talked about version this and this, but it also can kind of get a little bit more concave or flattened, depending on when you throw, how much you're throwing. Some people even think like if you play softball, it's different than baseball, or if you have a quarterback, because it's a slightly different motion, or a javelin thrower, or a tennis player, etc. So again, sorry, I'm not trying to avoid the question. It's just, it's such a, there's so many factors.
So many factors that are involved with that.
Yes. So kind of go back to the internal rotational deficit. We believe that anything less than 25 degrees of a loss of internal rotation, or not having 180 degrees of a total arc of motion, is what our quote unquote danger zone is. And basically why this happens is, like we talked about that acceleration, deceleration, when you follow through, you have to contract the muscles as the arms sort of, for lack of a better term, and hopefully you guys can see, I'm going to turn the light on, it's getting a little dark in here. As you go from this position and you throw down and you're throwing here, the arm sort of telescopes forward and it will peel the bottom half of the labrum and, the capsule, and sort of peel it off. It gets subjected to sort of a stress trauma. Well, if you do that, 250 times, what happens is that capsule bleeds and scars a little. And when it does, if you take something and like cut your arm and it bleeds, it makes a scab and it kind of contracts, it gets tighter. And so that's exactly what happens in the back bottom portion of that hammock we're talking about. Okay. So when that starts to happen, that's when you start getting issues with damage to other structures inside the shoulder. And particularly, you'll start having adaptations by the athlete with their scapula to try and overcome some of these issues. And I'm just using this posterior capsule as one of the main issues we see the most of. And I do want to take a step back. The one thing I didn't put a slide in here, but obviously we want to be able to measure these things. And I tell most parents, and most coaches that it's very advisable to sort of get video and or pictures of your athletes and measure what their external and internal rotation is prior to starting the season. It's incredibly easy to do. We all have video, we all have the phones and the cameras. You can take pictures and show where both the left and right are, and you can use either here or you can put it behind the back to show people and have pictures. And we know from studies, as you go through the season, some people will develop, again, a little bit more than 180 degrees of range of motion, and they will stretch out. And there's a couple of studies that show in pro athletes, college, even high school, that you start stretching out a little bit more as you go from the beginning of the season to the end of the season. And the reason you stretch out is because you're stretching out that bottom part of the hammock again. So I highly advise all the coaches, parents, etc., do a benchmark. You can have that saved on your phone. Do it for all your players. And maybe periodically, every couple months, or as kids transition from maybe one travel ball team to high school or whatever else they're playing, assess those again. And we can, you can even bring it to your trainer, to your physical therapist, to your doctor, and go, here's what's going on.
I think one thing we may be able to do is do an example, maybe like that we will blast out to everybody who's on the thread tonight, of exactly what that looks like. What angles are good to take pictures from, and so on and so forth, so that they have an idea of doing exactly what you said.
We can do something like that. We can do a video for illustration purposes. Again, you can see the diagram that's on here now. You can kind of see where these arms are at. And what I would recommend is basically taking a picture from sort of the front. It's much better to get an angle from the side. And you can do this from someone just laying down on a chair, laying down on a table or a bed. But you can easily just have someone, and I'll demonstrate. If you, just like you're watching me now, you can, if you get the arm in a sort of a neutral position and have them go back and take a picture. and then have them come forward. And it's easier if you're lying down, but you can do it standing up as well. Or you can just get the individual, the athlete, and just video that with your phone and take those pictures. The other one I'm talking about, if you want to do internal rotation, it's a little bit more reproducible because people can change their arm angle, is to have them put their hand behind their back as high as they can. And that's why this slide is up there. But we can always do, I guess, a demonstration one day. We'll just have somebody video it.
Sure.
Let's proceed. How are we doing? Are we doing okay on time, etc., stuff like that? I know we're going a little bit here.
Yeah, we're coming up. We're about 10 minutes shy of 8 o'clock. So we've got probably about 10 more minutes.
Okay. Well, why don't we do this? We'll talk about some stuff, and I'll get a little bit to the stretches and the other things here, and we can talk a little bit more about the other issues. So again, and I'm going to go a little faster. This is what we call the sixth scapula. This is, again, something that I want the picture up to see, and again, something that people can do very easily. I frequently let people come into my office and take their shirt off and have this picture right here. And what I have them do is elevate their shoulder blades, or I will have them take this and I just say, pray for me. And I have them hold their hands out and squeeze. When they do this maneuver, you will know if their scapula is doing what it's supposed to. Sometimes, again, I'll take the patient's phone and video it and show them, and they'll see how one scapula goes like this and one goes like that. And when I'm explaining all these things, it becomes very obvious to them. The reason why this happens is because, again, going all the way back, is that one, those muscles that are around the shoulder are not in balance, and two, we've stretched out most of the bottom part of the capsule, and now we're a little bit tighter in the back part of the capsule, and now we're causing wear and tear in that labrum, the biceps tendon, and those structures. Lastly, when this process continues to keep going and going and going, you get this term, what we call internal impingement. And essentially what it is that the humerus and the capsule is so lax in some areas and so tight in others. So, and this just shows you this little picture here. You are literally dragging the back half of the rotator cuff into the socket because it's gotten tight back here and it's loose down here. And again, you can see how the ball is pointing almost completely down. And that is the position you get here. And the reason why I leave this up here now is because I kind of want to lead to talking about the muscles, etc. You've got to get this scapula to move out of the way of this portion of the bone. So this portion of the humeral head will pinch this rotator cuff in between here in the socket, as well as in between the acromion and the humeral head. And what it does is it tears the rotator cuff from the inside out. It's called an articular surface tear, or some people refer to it as a pasta lesion, and it stands for a partial articular sided rotator cuff tear, basically. And that's what you see right here. That's this arrow. There's the biceps tendon. There's the labrum all beat up top, because as the ball is decelerating and being pushed up from the back, as it rotates through, it just tears the heck out of that labrum. What that does is then cause pain, and now the person starts changing the way they throw, they move, etc. Now the firing of these muscle units starts getting changed, and now the shoulder blade and scapula starts moving differently, which further progresses this. It's like a snowball, like, if you watch cartoons where Bugs Bunny drops the pebble at the top of the mountain and it gathers steam going all the way down. So, how do we prevent all this? The main things are, one, shoulder balance. We've talked about this. You have to have balance in the shoulder. And we're talking about not only muscular balance, but ligamentous balance. And again, another aspect, and this is kind of higher level stuff, is not only do we have to have balance, but we have to maintain that balance as we're doing a high velocity, kinetic, multi-joint movement. And that's where repetition, coaching, visual cues, all those things play a dramatic role. But we're going to talk a little bit about these three things here. We talked again about how all these muscles tilt and move the scapula. And again, this is a busy slide, but hopefully you guys can see, you know, the rotator cuff, like we talked about, most of it controls that posterior portion and stabilize the scapula against the rib cage. It also, at the beginning part, helps, as we talked about with that pinching part, all the rotator cuff externally rotates the arm here. But if you don't have the trapezius, the rhomboids, the levator scapula elevating the shoulder blade, you're going to, as you start to rotate this guy, if the shoulder blade doesn't rotate and clear out of the way, what happens? You get that internal impingement. So again, that's where the muscular forces can help sort of diminish your chances for injury. So what do? Well, these are some common stretches that people are probably aware of. The number one stretch everybody hears about is this guy right here. It's called the sleeper stretch. And I will tell you, it is, well, more people know about it, but I used to say it was basically the most undervalued stretch you could possibly do in an overhead athlete. And you can see there's a demonstration of it there. You basically start with your arm and you kind of trap the elbow and you force it to internally rotate, stretching that posterior capsule. And there's various versions of that. It's very easy. You can go online and find these things very easily. YouTube demonstrations, etc. If there's ever any problems, I always tell people, sometimes consulting with your local physical therapist, which nowadays you don't even need a prescription to go to a physical therapist. You can just go to them. Most insurances will make you come to see me, someone like me eventually, but you can go to physical therapists just right off and have them show you some of these things. The other stretches that we all worry about is the deltoid here. And that stretches really all these posterior capsule structures. A lot of these stretches here stretch more than one thing. You know, they're stretching all sorts of tissues in the back and or the front. And the key thing again is making sure you have balance. One of the other stretches that are frequently used is this pec minor or pec, and you stretch your pec major as well. But the key thing when we talked about the pec minor, when the pectoralis minor and the pectoralis muscles get tight, it tends to bring the shoulders forward. And that is a big deal because if they're forward or protracted, it's harder to retract it to clear so you can get the external rotation. So these two stretches, sorry, I'm pointing, you guys can't see, but these two stretches here, I can't speak highly enough of. That being said, it is not the only thing that matters. Occasionally we'll see people where they're stretching. And remember we talked about the front part of the capsule getting stretched out. Well, now you're stretching at the back. Well, you can, and I see this frequently, where the whole bottom is really stretched out. And then it's gonna matter about the muscular forces around there to hold it. I've had a number of patients where they've gone and done all these stretches and they're so stretched out at the bottom that I have to go in and do something to sort of tighten them up, because a lot of pitchers and throwers have what we call ligamentous laxity. So that capsule is very stretchy. And most people, you probably, Jack, when you look for pitchers, I'm guessing you look to see if they're quote unquote double jointed and how much ligamentous laxity they have, because that stretchiness creates the whip effect and creates velocity. It's kind of like, if you ever seen highlight, where they have the thing and they throw it out of it, creates that sort of slingshot effect. The problem is it comes at a price if you can't hold everything together. And remember the picture where you saw the glenoid on face, all those muscles that are holding it. Any other questions?
Right now, we got a couple generalized questions that we were going to kind of save towards the end after you got finished your anatomical review.
I've got maybe 5-10 more minutes, and we can do that.
Sure.
So in the line with the stretches, I do like use of devices and things that can help you. TheraBands, dumbbells, these things for as far as stretches, like a towel or a wand is great for doing some of these stretches. And again, you can go online and see how you can use the wand or broomstick, etc., to help use one arm to stretch the other, and things like this. There are tons of resources here that you can go online. Again, look up on your own. You can go and talk to myself, to a physical therapist. These resources are out there, and they're very easy to get. And I can't emphasize enough about making sure you monitor that range of motion, etc., and stretching accordingly. Finally,
are these stretches limited to an age group, or are
no,
these
not necessarily. But as a general rule, obviously when people are younger, they're sort of they're definitely more pliable. They have I don't want to get too much into anatomy, but we're all a lot more stretchy when we're younger. And that's a whole nother story of the reason why.
Feeling kind of stretchy.
But they'll respond to those stretches a little bit better, and it doesn't take as much effort. If you do some periodic stretches and just monitor things periodically as they're younger, it becomes much easier to deal with if they start having issue later, because they sort of laid the groundwork for this. And now you're not, again, dealing with the snowball that's rolled downhill. I use this slide as a little bit of a tongue-in-cheek here. I use this example all the time with my patients when they talk about their shoulders. If you're talking about doing something that involves the shoulder, throwing, swimming, tennis, etc., you want to look like Michael Phelps, and you don't want to look like DK Metcalf. Hopefully you guys know who these people are. Obviously, you can see, like, just for example, look at Michael Phelps. He is not nearly as developed in the pectoral area, but if you look at his back, it's like, I mean, you could use that instead of the slide I did before. Every single muscle back here around his scapula is incredible. And again, think about what he asks his body to do. He basically telescopes and dislocates his arms to bring water and pull it behind him. I mean, he puts as much stress on both of his shoulders as any human being will ever do. And how does he do that and no one doesn't get injured at all, but get injured minimally? That is why right there. If you are built like this, I'm not saying you can't be a baseball pitcher, but it's a hell of a lot harder because of these muscles and the way that it brings, and you can just see, how Michael Phelps' shoulders sit back, and you can see how their shoulders, now granted they're flexing, but still their shoulders sit so much far forward. And again, it matters where all that is, depending on what kind of sport you do. Obviously, if you're a swimmer, it makes a difference. You're a baseball player, it makes a difference. You're a football player, it makes a difference. So I put these back exercises. I'm hoping that I'm not overwhelming people here, because I'm kind of hoping that either A, people are familiar with these, or B, they feel comfortable going and looking some of these things online, or having maybe their physical therapist or their trainer going over with it. The one thing I can't emphasize enough is you're going to see a ton of exercises. I can't emphasize enough the importance of controlling the scapula. And so I'll kind of do it from the back, and hopefully you can see me. But you want to control the scapula and bring the shoulder blades back. When you're doing those exercises, you should bring those scapula together. And there's a lot of ones, like exercises where people will actually put a ball or something between their shoulder blades to sort of activate the brain to pull it together. And doing these kind of exercises is tremendous in making sure that the scapula can retract when you go here. And then not only that, but protract and propel forward when you throw, which again will generate velocity. I always tell people I love deadlifts. I think deadlifts are great because not only does it link the lower extremities to the core to the upper extremities, and particularly, obviously, deadlifts work the trapezius, they work all the spinal muscles. You can do that in various ways. Some people will do it with a leg spread, which is called sumo. I actually recommend doing both ways, conventional and sumo. rows. You can do this in any number of ways. You can do it with your hands here. You can do it with your hands apart. You can do them bent over. You can do them with dumbbells. You can do it with bands. You can do it with cables. All those are work. The key thing again is balancing it out, doing some things with the hands closer in and some of them with the hands further out and away from the body. Pull downs. There's a lot of different exercises, some that involve pulling a cable down this way, or actually what we call diagonals or pull throughs in this direction. And all of those, again, not only work these muscles around the posterior scapula, but they also start having you work them through a different range of motion and activating them in sort of a timing sequence. Likewise, reverse flies. I love having kids do exercises either on a bench, or one way you can do that is a Bosu ball, one of the exercise balls where you can lay on it and you can do various exercises where you bring your arms out and do several things. Finally, these are some of the things that a lot of people may read about. People will call them like W's or T's or I's. You can do them where you lay on a ball and you can move your arm in various different directions, like a W. You can move your arm and do maneuvers like this with dumbbells or bands. And there are also plenty of other exercises where one can take the dumbbell or band and excellently rotate here. They can do it in this position here. They can do it while seated. They can do it while laying down prone. Again, you can use dumbbells, etc. I also like raises, like upright rows and raises where we're using cables or bands. And again, obviously, if you're going to do things for more repetitions, etc., you're going to want to use lesser weights, etc. And I actually recommend people doing things where they build, they have a period of building muscle where it's a little bit more repetition, somewhere in the 8 to 12 reps. And then a time where they refine that muscle to optimum strength, where they're doing somewhere in the 3 to 5 repetitions. That's for a shorter period of time. And I usually recommend doing that as you're about to enter into the season, because one, it's a little bit less strain and volume, and two, it optimizes strength. There's a little bit of a controversy on whether or not you can avoid presses. A lot of people feel like you should not do overhead presses or bench presses because of the shear that it places on the shoulder and the fact that it puts this stress on the inferior portion of the capsule, and it creates more impingement. I'm not one of those people. I do think you should avoid putting your hands in a position where it's behind your head or neck because that's generating some impingement. I do think it's reasonable to do bench presses, incline presses, etc. But I say in a tremendous amount of moderation. I do think doing things like push-ups. I love having kids do push-ups on what are called Bosu balls, the half moon balls, because it controls. If you're on a ball, it makes you control your scapula in the air.
Jason, we got a quick question in regards to lifting. What age is good to start lifting with weights? And with younger kids, are bands better than weights?
I am not aware of a study that has demonstrated any better efficacy or safety in regards to starting a particular age group with bands versus weights. One of the misnomers is that heavier weights or overhead weights may cause compression of what's called the physes, the growth plates, and stunt growth. That doesn't really completely hold true. There are some studies that say if you're doing higher weights, such as power lifters, Olympic lifters, etc., and doing it frequently, that can occur. There are others that argue that sort of the genetic component of growth is a much larger determinant, and how much growth hormone your body secretes during that time of ossification. So me personally, I have no problem with younger children using dumbbells, barbells, etc. However, I highly recommend that they're monitored very closely in regards to form, and or frequency, because you can overtrain fairly quickly, especially if you're not having variation and working other muscle groups. Does that answer the question?
Yeah, I believe so. And we got another one that came in. It says, how important is strengthening and activating serratus anterior to help relax anterior shoulder muscles and pectoral?
It matters. And to get specific, the serratus anterior, as it contracts, pulls that scapula against the thoracic cage and stabilizes it. So those and exercises that work that, like some of these rows, like lat pull downs, like some of these other exercises, all help stabilize the scapula. And again, they're very important. The problem is, I think people tend to get focused on one muscle or another. And granted, you have to do certain exercises to sort of target them, but most of the really good exercises target multiple muscle groups. And that's this is my personal feeling. There is some studies that lend credence to that, but I'm sure we could get another doctor that may argue differently, or a therapist that may argue differently. But I would argue, whoever's asking that question, I think it's tremendously important. But I don't think you necessarily have to be like, oh my goodness, I got to go do my serratus anterior exercises.
Gotcha.
One thing that, and this is, we're near the end here, the number one thing that all of this matters is controlling the arm in space. So this is something that we do in our therapy, is we have these athletes use their arm, like for example, have a ball against the wall, and they'll control the ball and the shoulder blade in space, or they'll use what's called a blade, and they'll control the arm in space. And what that does is it makes you activate all these muscles through an entire range of motion and in different areas and places away from the body. And why that matters is because it does this big thing right here. It's called proprioception. That area, if you look at a brain, there's a thing that kind of looks like the butt on the back of it. It's called the cerebellum. That controls, if anyone's ever wondered, like if I close my eyes and I put my finger here, I can pretty much hit it, almost hit it with my eyes closed. Why? Because my brain knows where my finger is out in space. And that's the area called the cerebellum. All of these exercises take that raw muscle and teaches the brain to fire those muscles in the appropriate firing sequence, like a distributor cap, so that you can throw a baseball, et cetera, and minimize that damage. And that's really where, this is where you fine tune and get all this stuff ready. Oh, sorry, that's my last slide. But obviously I'm open to any and all questions.
No, that was Jason. That's awesome. And I think a lot of times what people fail to realize is the value of understanding what parts of the anatomy are working and which ones have a tendency to be a little bit more disrupted through the course of throwing. I know you get a lot of kids. I've been a catching instructor for almost 20 years, and it never fails when you get some kids that have a little tenderness. They're always like, oh man, I hurt right up in here, and you can almost press on their bicep tendon and just be like, okay, well, it almost kind of seems like you got a little bit of inflammation right here in that bicep. It's not a labral tear, it's not a rotator cuff tear, but it's a little bit inflamed right here. And I think just having a generalized understanding of the muscle groups that are activating, it'll help you in order to know how to basically develop those specific muscles to help with the process of throwing over the course of a career. And especially, the big thing is earlier on, we discussed how to get kids throwing a baseball to help the development and time of those anatomical changes. But I think what you said was most important is finding that balance so that it's almost like you're developing a healthy arm at a young age by introducing the idea of throwing, but in the same sense, you have to be able to balance it, because any amount of overdoing it is going to backfire on you.
No, I couldn't agree anymore. And again, it's different for different kids and at different age levels. And obviously, a lot of times these children want to play, they want to throw, they want to do stuff, and you've got to have parents that are willing to kind of hit the brakes on it and have them do something else as far as an athletic endeavor, etc. I can't emphasize enough to your viewers, while obviously we're talking about baseball, I as a shoulder doctor, the number one thing that makes all my hair fall out, is that when parents tell me their kids play one sport, and most of the time it's baseball, and they play it nearly year round, it is absolutely positively the number one reason we see kids with injuries is that they do not play another sport. And I can tell you from speaking with coaches, scouts, etc., a lot of coaches and scouts want kids who have, for lack of a better term, untapped potential. They'd rather your child played something else and not maybe been playing baseball and refining their craft, etc., whatnot, the whole time, because it gives them, for lack of a better term, something to work with. They'd rather take this quote unquote athlete and make them. And I think doing all those other sports helps you get better by creating balance in your chosen sport, so to speak.
Yeah, I think, and I love that you said that, Dr. Rowland, because I know like in our program, we're a baseball program, but we 100% support our 2-sport athletes or 3-sport athletes and encourage those kids. And it's also, part of our, yearly calendar where four months of the 12 months are complete rest periods for our program. So for our baseball only players, those kids that do only play baseball, we have a, basically November, December, and January, which is a complete off period from throwing or competition. And then also we have a month and a half in between the end of the summer, before the fall. So we, very, very important point there. And it's I'm so glad you shared that with us. And even just from a medical perspective of playing multiple sports and how that can benefit young people. So that was a great point. Thank you for saying that.
No problem. One thing you'll find is I'm at times brutally honest, and sometimes every now and then, like I said, I'll speak my mind, etc. And so if people have questions, take umbrage, they're more than willing to text in, call in, whatever. And a lot of this stuff, there's a few things that are pretty hard fast, but most of this is kind of up for discussion and or interpretation too. So don't take what I'm telling you as gospel. There's a lot of very good resources out there. And like I said, I think obviously you guys are a great resource as far as going like, hey, what websites do you guys like for this and this and this? And again, your local trainer, your physical therapist, etc., those people as well.
Well, Jason, we appreciate your time, man, and I thoroughly enjoyed it. I know Jack and I were discussing some things along the way, and I'm sure a lot of our viewers got a lot out of it, and we look forward to being able to get together with you more often in the future to discuss certain things that may pop up over the course of time, and we may ultimately change some of the different things that we talk about based off of things that pop up. But I do want to say thank you, and we look forward to having you on for some more very intelligent, insightful discussion.
Thanks, guys. Thank you for having me. And again, if you want to have like a particular topic and you decide, just let me know, and I can be more than willing to help.
Yeah, and Dr. Rowland, real quick, I know we had briefly talked about earlier today about sending out maybe your clinic's email address or something that we could share with our folks. Is that okay still?
Yes. Here, let me, I'll share the screen here one more time. It's at the beginning, maybe. You said yesterday, because I've been talking so long, it seems like another day.
Hey, we could talk for 2 more hours.
I really enjoyed it.
I'm very much locked in.
I'm amazed my dogs didn't bark. That's like the first time in a long time. Every time I've done one of these meetings over the last few weeks, it seems like my dogs go crazy. But again, hopefully your viewers can see this is my email address. I have a clinic, Covington Orthopedic Clinic. I mean, if people are ready and writing it down, the number is 892-5117, and that is my clinic. And if there's a question, if there's someone that, people need to get examined or just want a referral to a therapist, to a trainer, to whatever, those are ways I can be reached. And if you see me on the street or whatever and you have a question, it's okay. You can stop me and ask me. I don't mind it. It makes my head get a little bigger, and my fiance doesn't mind too much either.
Well, that's awesome. Really, just on behalf of tonight's program, Dr. Rowland, thank you so much for your time and sharing this great insight. And I know we're going to put this out to our entire program for those that weren't here tonight. So it'll be an incredible resource for our players. And I just want to really just sincerely thank you for your time.
No worries, guys. My pleasure. And you had lots of fun.
Awesome.
Talk to y'all later.
Okay, thank you.
You bet. Bye-bye.
Yeah, I don't know.
I need to relinquish control, Jason.
Can you? Okay. Okay. Yeah. So guys, I know we said earlier, we were going to do the trivia question for a pair of Marucci sunglasses. So here's the question. Okay. It looks like we've got 39 attendees left. Okay. So the question, the trivia question is this: what Major League club drafted Jeff Winchester in 1998, and in what round was he drafted? So if you want to answer the question, you got to put it in the Zoom chat and tell us which Major League club drafted Jeff Winchester and what round he was drafted in.
So long ago, nobody even knows.
Wow, Colin Hurley. Now that's almost not fair, Hurley, because you guys are like really close friends with the Winchesters, I think, right?
Yeah, we definitely know the Hurleys for sure.
Langdon, Rocky second round. Look at Holiday, Colorado first. That's pretty good. I tell you what, Hurley, Cade Woods says Colorado Rockies in the second. Wow, look at all this. We got a lot of. Well, Colin Hurley was the first. Mason Langdon said Rocky's second round. Technically, it was the supplemental first round. So second round, we can't give you credit for because it was the supplemental first round, pick number 40. So we're going to go with Colin Hurley, who was first, was the first correct answer. So Colin Hurley will get a pair of Marucci sunglasses. So.
At least we know we can turn to you for useless information.
Sorry, Cade. Cade says, dang, come on, coach. Sorry about that. You were close. But, hey, guys, I hope y'all enjoyed this. We really appreciate Jeff Winchester putting that together, and we're going to have some more of these coming up soon with like a nutritionist talking about diet and also some vision training and some things we can do as players to improve. Really a great addition to our program, having Jeff Winchester lead these efforts. It just really, as players for you guys, it's just a great resource. So thank you, Coach Jeff.
All right, guys. My pleasure, and we look forward to doing the next one.
All right, guys. Y'all take care. Be good.
Thanks for hanging around.